Welcome to the funnel effect.
Great to be diving into this.
Today, we are tackling a really crucial topic, one that sits right at the intersection of electrophysiology and heart failure, arrhythmia-induced cardiomyopathy, or ACM, as it's often called.
Exactly. And this deep dive is grounded in a really comprehensive JCC state-of-the-art review, Arrhythmia-Induced Cardiomyopathy. It's by Priya Qureshi, Alex Whitehan, John T. Konaru, Kenneth A. Ellenbogen, Carolee Kazala, and Jose F. Huizar.
A fantastic resource.
Absolutely indispensable, I'd say, for anyone in modern cardiology. Our goal today really is to cut through some of the clinical fog that often surrounds this.
That challenge of figuring out when a heart rhythm problem and arrhythmia isn't just happening alongside heart failure, but is actually the main driver.
Precisely. When it's causing a specific and often remarkably reversible form of non-ischemic heart muscle disease, cardiomyopathy.
And that's the classic clinical headache, isn't it? The chicken or the egg scenario. We know heart failure can definitely trigger arrhythmias.
Oh, for sure.
But this research really drives home that the arrhythmia causing the heart failure is, well, it's a distinct and powerful thing we just can't afford to miss.
You've hit the nail on the head. We're focusing squarely on arrhythmia-induced cardiomyopathy, ACM. And importantly, this isn't just about, say, a fast heart rate making existing heart disease worse.
Right.
This is about the arrhythmia itself being the primary factor leading to that left ventricular systolic dysfunction, often in a heart that was, structurally pretty normal beforehand.
And the authors point out what makes it so tricky to pin down is this underlying mystery. Why does one person develop severe cardiomyopathy with a certain arrhythmia load, while someone else with basically the same rhythm issue seems totally fine clinically? That individual susceptibility seems key.
It's the fundamental question, isn't it? And it's what makes early diagnosis so critical. To help clinicians avoid missing ACM, the review lays out some very specific criteria.
Yeah.
Things that should immediately make you suspicious.
Okay, what are those triggers?
Clinically, you really need to have ACM on your radar if the patient has a mean heart rate that's consistently over 100 beats per minute.
Okay, sustained tachycardia.
Yes. Or if they have atrial fibrillation, doesn't matter if it's proximal or persistent. And crucially, this is a big one, if they have a premature ventricular contraction, a PVC, burden that's higher than 10%.
That 10% PVC number feels like a pretty clear line. But just being suspicious isn't the final diagnosis, I take it.
No, not at all. Suspicion gets you started, but the definitive confirmation of ACM is actually retrospective. It hinges entirely on what happens after treatment.
Ah, so you only know for sure after you fix the rhythm.
Exactly. The diagnosis is confirmed only when the cardiomyopathy, the LV dysfunction, actually reverses once you've successfully gotten rid of the culprit arrhythmia. That functional recovery, seeing the heart bounce back, that's the absolute definition.
That really raises the stakes then, because you're talking about a potential cure, not just lifelong management.
It's potentially curative. That's the hope.
So what are the three main types of ACM we'll be exploring based on this review?
We'll break it down into three main categories. First, tachycardia-induced cardiomyopathy, TCM, which is really driven by the high rate.
Yeah.
Second, atrial fibrillation-induced cardiomyopathy, or AFCM. That one's thought to be more about the irregularity, even if the rate's controlled.
Interesting distinction.
And third, premature ventricular contraction-induced cardiomyopathy, PVCCM. There, it's about the frequency and maybe the origin of those extra beats. These three really cover the main electrophysiological causes.
And if clinicians can accurately identify these early on, the downstream benefits sound enormous.
Oh, absolutely massive. Getting the diagnosis right and getting it early has this profound potential. You could potentially return the patient's heart function completely to normal.
Which transforms their quality of life, obviously.
Dramatically enhances it. And beyond that, it improves clinical outcomes. It drastically cuts down on hospital visits for heart failure flares. And ultimately, it saves the healthcare system money because you're providing a targeted, maybe even permanent fix instead of just managing a chronic disease forever.
Okay, let's dive into that first category then. Tachycardia-induced cardiomyopathy, or TCM. This sounds like the most sort of historically recognized form.
It is. TCM is defined pretty straightforwardly.
Yeah.
It's reversible left ventricular dysfunction that's primarily caused by just a sustained increased ventricular rate. It doesn't really matter where the tachycardia is coming from.
It's the speed itself.
It's the sheer speed, the relentless workload on the heart muscle. That's the problem in TCM.
And you mentioned it's been recognized for a while.
It has, yeah. Descriptions of TCM go way back, actually, to the early 20th century. But, for a long time, there was skepticism because proving the direct cause and effect in humans was really difficult.
So what changed? What solidified it as a real entity?
The game changer was the development of experimental animal models. As far back as 1962, researchers showed they could reliably cause LV dysfunction just by rapidly pacing the hearts of dogs that were otherwise structurally normal.
Ah, the pacing model.
Exactly. That experimental proof was absolutely crucial. It showed that the rapid rate alone, without any other underlying disease, could actually create the cardiomyopathy.
That animal data really laid the foundation, but given that history, why does the review say the overall prevalence today is still kind of uncertain?
Well, the uncertainty really comes down to misdiagnosis, I think. The symptoms, the echo findings, they can look exactly like generic dilated cardiomyopathy, or DCM.
So cases get missed.
It's very likely.
Hmm.
A lot of cases that get labeled idiopathic DCM, meaning we don't know the cause, could actually be undiagnosed TCM. But when you look at specific types of tachyarrhythmias, the risk becomes much clearer.
Okay, let's talk about those. Which rhythms carry the highest risk for TCM?
The absolute highest association is with something called permanent junctional reciprocating tachycardia, or PJRT. Yeah, it's a type of incessant supraventricular tachycardia, meaning it's basically running all the time. And in patients with PJRT, the prevalence of TCM is huge, somewhere between 20% and even 50%.
Wow, up to half.
It's significant. Atrial tachycardia is another big one. Overall, maybe a 10% prevalence of TCM with AT, but if that atrial tachycardia is incessant or really hard to stop, that number jumps dramatically to around 37%.
So incessant really is the key word there. Constant high rate equals high risk. But in terms of what clinicians see most often, what are the most common culprits overall?
Just by sheer volume, the most frequent causes are supraventricular arrhythmias, primarily atrial fibrillation and atrial flutter, especially when they present with a rapid ventricular response, RVR.
AFib with RVR, yeah, see that all the time.
Exactly. Beyond those, you also see things like AV reciprocating tachycardia, AV nodal reentrant tachycardia, and interestingly, even sustained inappropriate sinus tachycardia can sometimes do it. We also can't forget frequent ventricular arrhythmias like VT arising from the bundles or fascicles.
Right. Which brings us back to that tricky diagnostic point, separating brand new TCM from just making existing heart disease worse.
That's the critical clinical distinction, differentiating de novo TCM from superimposed TCM. You absolutely have to consider TCM even if a rapid heart rate seems to be worsening a cardiomyopathy that was already there.
Like from a prior heart attack or something.
Exactly, whether it's ischemic, infiltrative, drug-induced, whatever. Treating the tachycardia in those superimposed cases is still incredibly important, even if you don't expect the LV function to return completely to normal because of the underlying damage or scar.
Okay, let's dig into the pathophysiology. What's actually happening inside the heart cells when they're being hammered by this rapid rate for days or weeks? This is the core mechanism, right?
It is, and the preclinical animal studies really give us the roadmap here. When you continuously pace these animals rapidly, they develop dilation in both ventricles and LV systolic dysfunction, but crucially without hypertrophy.
No thickening of the muscle wall.
No thickening. That's important because it distinguishes TCM from conditions caused by pressure overload, like hypertension or aortic stenosis. TCM looks more like volume overload damage.
Can you walk us through the timeline? How quickly does the heart decline in these models?
It's a fairly distinct progression. Initially, maybe for the first week or so of rapid pacing, the heart kind of tries to stabilize, maybe some neurohormonal compensation kicks in.
Okay.
But then the cardiac output and the LVEF just relentlessly decline over the next 4 weeks. And this typically leads to obvious symptomatic heart failure within about 2 to 3 weeks of that sustained rapid rate starting.
And what about the changes happening at the cellular level? What's the immediate hit?
Well, TCM involves profound changes, both structural and functional. The big ones are electrical remodeling and, very importantly, calcium remodeling. The core functional problem seems to be a failure in excitation-contraction coupling.
How the electrical signal makes the muscle contract.
Precisely. The rapid pacing essentially doesn't give the myocyte enough time to properly reload its calcium stores between beats. We see specific problems like impaired calcium handling dynamics, the calcium transients are reduced, the L-type calcium current is reduced.
So not enough calcium cycling properly.
Right. And that breakdown means the muscle fiber just can't contract or relax efficiently, which directly leads to that drop in LVEF we see.
Okay, so the functional decline is clear, but the review emphasizes the recovery speed can be astonishingly fast. How fast are we talking?
It's probably the single most defining characteristic of ACM, really. As soon as you stop the tachycardia, you see significant measurable improvement in LVEF and cardiac output within just 48 hours.
Wow, 2 days.
It's incredibly quick. And full normalization of function often happens within 1 to 2 weeks. That's just lightning fast compared to recovery from, say, an ischemic injury or a genetic cardiomyopathy.
And this is the crucial caveat you mentioned earlier, the one that should really make us think. What structural problems remain even after the LVEF looks normal again?
This is a major, major insight from the review, and it's critical for thinking about long-term prognosis. Even after the LVEF normalizes, studies show the left ventricular mass actually increases, a subtle sign of ongoing remodeling. The LV often stays somewhat dilated too.
Still enlarged.
Still enlarged. But the most critical finding, the one with the biggest implications, is that underlying fibrosis persists in the heart muscle. You still see myocyte misalignment, you still see patches of scar tissue, even when the echo report says the ejection fraction is back to 55%.
Wow. Okay, if the heart is pumping normally but it's structurally scarred, that directly explains the increased risk we talked about earlier, doesn't it? Why is the risk of sudden cardiac death still elevated?
Because those residual structural abnormalities, the fibrosis, the myocyte disarray, they create what we call an arrhythmogenic substrate.
A setup for bad rhythms.
Exactly. It provides pathways for potentially lethal reentrant arrhythmias like VT or VF to develop even if the overall pump function, the LVEF, looks fine on the surface.
Yeah.
This is why sudden cardiac death remains a persistent danger, reported in maybe 8% to 12% of TCM cases, even after they've had successful rhythm control. It really challenges our notion of what constitutes a full recovery.
Yeah, it forces us to look beyond just the LVEF number as the only measure of success. Okay, let's shift to the clinical side. What does a typical TCM patient look like when they present?
Well, the timeline for development can be incredibly variable. It might range from just a few days, literally 3 days in some reports, up to maybe 120 days from when the incessant tachycardia starts until the LVEF really tanks, sometimes dropping below 35%.
And the symptoms they come in with might not scream arrhythmia, right? They often mask the cause.
That's very true. While maybe about 29% report palpitations, which points towards a rhythm issue, a large chunk, nearly half, 47%,
Yeah.
present with classic severe heart failure symptoms,
Huh.
NYHA class 3 or 4, often needing urgent hospitalization. A smaller group, maybe 12%, might experience syncope or pre-syncope. But we also have to remember there's an asymptomatic group out there, which makes early detection incredibly challenging.
Right. So beyond the echocardiogram, what diagnostic tools are absolutely essential?
Ambulatory ECG monitoring is key. And not just for 24 hours. You really need at least 2 weeks of monitoring to properly quantify the rhythm burden and catch any intermittent or paroxysmal tachycardias that might be causing the problem.
2 weeks minimum.
Minimum. Then, of course, an echocardiogram, or even better, cardiac MRI, CMR, is vital to rule out other potential causes of a dilated cardiomyopathy. What you typically see with TCM is that dilated picture of moderate to severe dysfunction of both ventricles, and this is key again, usually without significant hypertrophy.
And you mentioned biomarkers, specifically BNP, can be helpful for rapid confirmation.
Yes, BNP and proBNP will generally be elevated just due to the heart failure state. But a really useful clue, highly supportive of TCM, is seeing a sudden, significant drop, like a 50% or more reduction in those proBNP levels within just 1 week after you successfully eliminate the culprit tachycardia.
That rapid fall suggests you stopped an active process.
Exactly. It strongly points towards an active reversible mechanism being turned off.
So treatment then is all about getting rid of that arrhythmia. What does that look like practically?
The primary goal is absolutely arrhythmia suppression. The best strategy really depends on the specific arrhythmia. For tachycardias that are considered curable, things like AV nodal reentrant tachycardia or certain focal atrial or ventricular tachycardias, radiofrequency ablation, RFA, is often the definitive first-line approach.
Ablation for a permanent fix.
Ideally, yes. For something like atrial fibrillation with RVR, the approach might be pulmonary vein isolation, PVI, if you're aiming for rhythm control, or potentially using antiarrhythmic drugs, AADs, to try and maintain sinus rhythm, though success rates vary.
And standard heart failure medications run alongside this.
Oh, absolutely essential. Optimizing guideline-directed medical therapy. Your beta blockers, ARNIs, SGLT2 inhibitors needs to happen concurrently. You start it or optimize it right away to help support the heart and promote that reverse remodeling while you're working on controlling the rhythm.
How quickly does the LVEF usually recover?
Improvement often starts almost immediately after rhythm control, but the bulk of the functional recovery typically takes about 4 to 12 weeks.
Now, what if the patient already had some underlying structural heart disease that superimposed TCM scenario? Is full recovery still on the table?
Statistically, full recovery back to a completely normal LVEF is less likely in those superimposed cases because of the pre-existing damage.
Right.
But treating the tachycardia is still critically important. Suppressing it provides significant symptomatic relief, often improves function somewhat, and crucially prevents further deterioration. You might not get them back to an EF of 60%, but you can often gain significant functional capacity and make them feel much better.
Okay, let's circle back to that really dangerous recurrence factor you mentioned. If the tachycardia comes back after initial treatment, what happens?
This is such a critical point for clinicians and patients to understand. If that tachycardia recurs, the TCM and the heart failure symptoms tend to come back much faster the second time around. Sooner, yeah. And often with similar or even worse severity than the first time. The heart seems to have a much shorter fuse, less resilience after that initial insult.
Which makes perfect sense if that underlying structural damage, the fibrosis, is still there, right? The heart's ability to cope has been fundamentally weakened.
That's exactly the thinking. This rapid recurrence really highlights how those persistent histopathological abnormalities, the leftover fibrosis and dilation, make the heart uniquely vulnerable to relapse. It underscores why achieving permanent definitive treatment of the tachycardia, especially through ablation for known curable circuits, is so vital for long-term management. You really want to prevent that rapid, severe, and potentially life-threatening recurrence.
Okay, that covers TCM really well. Now let's transition to the second form, which sounds like it introduces a whole new layer of complexity. Atrial fibrillation-induced cardiomyopathy, or AFCM. You mentioned the key difference hinges on rate control.
Yes, that distinction is absolutely paramount for understanding and diagnosing AFCM. It specifically refers to LV systolic dysfunction developing in a patient who has AF, but despite having what we'd consider adequate rate control.
So unlike TCM, where the fast rate is the problem?
Right, in TCM, you eliminate the high rate, and ideally, the CM resolves. In AFCM, the average rate might be perfectly fine, maybe 70 or 80 beats per minute, yet the LV function still doesn't recover or even declines. This strongly suggests that something other than just the rate is driving the damage.
So the million-dollar question is, if the rate is controlled, what is causing the cardiomyopathy? The review suggests the mechanisms are pretty complex and maybe not fully nailed down yet.
That's precisely the major knowledge gap we face with AFCM. The mechanisms are thought to be multifactorial, a combination of things. First, even if the average rate is okay, the inherent irregularity of the rhythm itself.
The chaotic beat-to-beat timing.
Exactly. That irregularity leads to variability in how the ventricle fills and contracts with each beat, and that's thought to cause abnormal calcium handling within the myocytes, similar in some ways to TCM, but driven by irregularity, not speed.
Okay, irregular calcium cycling. What else?
Second, there's the mechanical consequence of losing effective atrial contraction, what some call atrial stunning. When the atria are fibrillating, they don't contract properly, they don't really help fill the ventricle.
Loss of the atrial kick.
Loss of the atrial kick. And this has downstream effects.
Right.
It can trigger the sympathetic nervous system, increasing wall stress. It can elevate filling pressures, leading to diastolic dysfunction. It can even cause secondary mitral regurgitation because the atrium and annulus might dilate.
That sympathetic activation sounds like the heart stuck in a low-level stress response, even if the pulse doesn't feel that fast. I also recall the review mentioning something about an energy crisis at the cellular level.
Yes, that's a really interesting and emerging area. Cellular insights are increasingly pointing towards metabolic problems. A recent trial suggested that mitochondrial dysfunction within the atrial muscle itself.
The cell's power plants.
Exactly. Dysfunction there, leading to reduced production of ATP, the basic energy currency of the cell, seems strongly linked to the development of heart failure in patients with persistent AF.
So the atrium is energy-starved, and that somehow impacts the ventricle.
The thinking is that this metabolic stress and energy deficit in the fibrillating atria contribute to the overall disease process, potentially through neurohormonal signaling or other pathways that then affect ventricular function. It's like the whole system is running inefficiently.
This complexity must make diagnosis incredibly difficult, especially since AF is just so incredibly common in patients who already have heart failure for other reasons.
It creates that classic diagnostic bind, doesn't it? Is the AF causing the cardiomyopathy, or did the underlying cardiomyopathy create the conditions, the stretched atrium, the fibrosis that then led to the AF starting? It's often very hard to untangle.
A real clinical challenge.
And a major scientific limitation here, unlike TCM and even PVCCM, is that we currently lack robust, reliable animal models specifically for AFCM.
Ah, no good way to study it directly in the lab.
Exactly. This really hampers our ability to investigate causality, figure out the specific triggers, and dissect the mechanisms in a controlled way. We're relying much more on human observational data and treatment outcomes.
Which means the diagnosis often remains one of exclusion, basically waiting to see what happens after treatment.
Pretty much, yes. You should suspect AFCM in a patient who presents with a non-ischemic cardiomyopathy and has persistent AF, particularly if their LV function just isn't getting better despite being on optimal medical therapy and having achieved good rate control.
So meds are maxed out, rate is good, but EF is still low.
That's the scenario. And the conclusive diagnosis, again mirroring the overall definition of ACM, really requires demonstrating that the LV systolic function significantly improves or even returns completely to normal after you successfully eliminate the AF long-term, which usually means through catheter ablation these days.
This situation must have really challenged the traditional rate control first strategy that dominated AF management for years, especially in heart failure patients. Was rate control just not delivering the goods in terms of reversing the CM?
In many cases, it wasn't. The observation that rate control alone often failed to reliably lead to CM reversal was a major catalyst for a shift in thinking. The clinical and research community started asking a critical question. Maybe it's not just the rate. Maybe the duration of AF and the detrimental effects of the chronic irregularity are actually more important drivers of LV dysfunction than the average ventricular rate itself.
That makes intuitive sense, and this is where those big rhythm control trials like Cabana and Camera MRI came in and seemed to shake things up. What did that data actually show?
The findings were pretty transformative, honestly. These large randomized trials provided compelling evidence supporting a more aggressive, earlier rhythm control strategy, specifically using ablation in patients with both AF and cardiomyopathy.
What kind of improvement did they see?
They showed really significant improvements in LVEF. We're talking an absolute increase ranging somewhere between 8% to as much as 18%. That kind of jump in EF was seen in roughly 60% to 70% of patients with AF and CM who were assigned to the ablation arm of these studies.
An 8 to 18% absolute increase? That's a massive improvement, far more than you'd typically expect from just tweaking medication.
It's a very substantial degree of cardiac recovery, yes, far beyond typical medical therapy effects alone in this population.
How did ablation stack up against just using antiarrhythmic drugs, ADs, to control the rhythm?
Well, ablation generally demonstrated superior and more durable success in maintaining sinus rhythm. Success rates for ablation typically range from 50% up to maybe 88%, depending on factors like how long the patient has had AF and whether it's paroxysmal or persistent.
And the drugs?
AEDs, historically, only achieve maybe 30% to 50% success in maintaining sinus rhythm long-term, and they're often limited by side effects that lead patients to stop taking them. The Cabana trial, in particular, showed that catheter ablation wasn't just better at rhythm control. It also provided significant benefits in terms of survival, reducing major cardiovascular events and substantially improving patients' overall quality of life compared to starting with drug therapy.
So the evidence seems strong for rhythm control via ablation. But ablation is still an invasive procedure. Is there any way to predict beforehand which patients are most likely to have their heart function recover, to avoid doing procedures that might not help?
That's a critical question for patient selection. And yes, thankfully, we do have tools now. This is where advanced cardiac imaging, specifically cardiac magnetic resonance, CMR, with late gadolinium enhancement, LGE, has become incredibly valuable as a screening tool.
CMR with LGE, looking for scar tissue.
Exactly. The landmark Camera MRI study was pivotal here. It found that the absence of significant ventricular scar, or having a total scar burden of less than 10% of the LV mass, was a strong and reliable predictor that the AFCM was likely reversible with successful ablation.
So less than 10% scar on CMR, it means a good chance of recovery.
A very good chance, yes. Conversely, if the CMR shows the ventricle has already sustained substantial, irreversible fibrotic damage, a lot of scar, then the likelihood of significant functional recovery after ablation is unfortunately quite low. That 10% threshold gives us a really useful objective piece of data.
That's incredibly helpful for counseling patients. Did successful ablation also show benefits for the structure of the atrium itself, where the AF originates?
Yes, and this kind of ties back to that potential energy deficit mechanism we discussed. Studies have shown that successfully eliminating AFs with ablation can lead to a measurable reduction in myocardial atrial fibrosis, which you can assess using techniques like T1 mapping on CMR.
So less scar in the atrium too.
Less scar, and also evidence of improved atrial remodeling. The atrium becomes less dilated, functions a bit better. Seeing this improvement in the atrial structure itself reinforces the idea that reversing the rhythm disturbance also helps heal the underlying structural pathology that was contributing to the whole problem.
Okay, excellent overview of AFCM. Let's move now to the third distinct category, which the review notes was recognized as its own entity much more recently, only around 2016, premature ventricular contraction cardiomyopathy, or PVCCM.
That's right. PVCCM is fundamentally different from the other two because the LV dysfunction is attributed solely to the presence of frequent PVCs, those extra heartbeats originating from the ventricles. And crucially, this occurs in the absence of any sustained tachycardia.
So it's not about a fast average rate like KCM or necessarily the irregularity like AFCM.
Exactly. It seems to be something about the sheer number and perhaps the specific characteristics of these isolated ectopic beats themselves that causes the damage over time.
Before we get into the damage mechanisms, let's talk about PVCs themselves. The review mentions they're incredibly common.
They are remarkably common, but the reported prevalence really highlights a key clinical point. It depends heavily on how long you monitor the patient.
How so?
Well, if you just do a standard 12-lead ECG, a snapshot in time, you might only pick up PVCs in about 1% to 4% of people.
Seems pretty low.
It does. But if you put a Holter monitor on someone for just 24 or 48 hours, that prevalence absolutely skyrockets. You'll find PVCs in somewhere between 40% and 75% of individuals.
Wow, a huge difference. Up to 3/4 of people might have them on longer monitoring.
Potentially, yes.
Yeah.
It really underscores why extended ambulatory monitoring is often necessary if you're trying to accurately assess someone's true PVC burden. A single ECG just doesn't cut it.
Okay, so if PVCs are that common, how frequent do they need to be before we start worrying about them actually causing cardiomyopathy? Is there a magic number?
The data suggests several tiers of risk, based on the PVC burden, which is usually expressed as a percentage of total heartbeats. The prevalence of actual PVCCM is estimated to be around 7% in patients whose burden consistently exceeds 10%.
So 10% is the initial flag.
It's the threshold where suspicion should definitely arise. However, the diagnosis becomes statistically much more likely as the burden increases, particularly when it hits thresholds of 16% and especially 24%.
Higher burden, higher risk.
Definitely. But it's also interesting, some studies have actually shown LVEF improvement after PVC suppression, even in patients with burdens as low as 6% to 8%. So it suggests there might not be a truly safe threshold below 10% for everyone.
And the risk associated with PVCs isn't just about developing cardiomyopathy, is it?
No, unfortunately not. Independent of CM, frequent PVCs have been shown to be an independent predictor of both all-cause mortality and cardiovascular mortality.
That's concerning.
It is. And the risk of developing systolic heart failure seems particularly elevated in certain groups. For example, the review highlights data showing that individuals under the age of 65 who have frequent PVCs experience a quite frightening 6-fold increased risk of developing systolic heart failure compared to their peers without frequent PVCs.
6 times the risk for younger people. That really emphasizes why we need to take high PVC burdens seriously, even in seemingly healthy individuals.
Absolutely. You can't just dismiss them, especially in younger patients.
Okay, let's dive into the mechanism. If it's not just the average rate and it's not just the irregularity, which animal models comparing atrial versus ventricular bigeminy seem to suggest, what exactly is it about a PVC that's so damaging to the ventricle over time?
It seems to be a really complex interplay of factors: electrical disturbances, chemical or metabolic issues, and mechanical stress all rolled into one. At the core, the contractile dysfunction appears strongly linked to major disruptions in the calcium-induced calcium release mechanism within the myocyte.
Calcium handling again.
Calcium handling seems central, yes, but maybe in a slightly different way here. The idea is that the premature ectopic beat might deplete the readily available calcium needed for the next normal beat, or it causes calcium overload during the PVC itself, leading to inefficient contraction and relaxation cycles.
So chronic beat-to-beat calcium mismanagement.
That seems to be a key part of it. This leads to myocyte fatigue and eventually that overall decline in LV systolic function, Like TCM, we also see electrophysiological remodeling and the development of fibrosis over time. But interestingly, unlike some other heart conditions, inflammation and programmed cell death, apoptosis, don't seem to be major players in PDCCM. It looks more like a mechanical and metabolic injury.
The review also placed a strong emphasis on the autonomic nervous system, that idea of autonomic imbalance. How can a single extra beat throw the whole nervous system control of the heart off kilter?
It acts as a chronic, repetitive stressor on the system. Frequent PVCs disrupt that delicate balance between the sympathetic, fight or flight, and parasympathetic, rest and digest, inputs to the heart. The net effect seems to be a state of persistent, imbalanced, sympathetic overload.
The heart's constantly getting that go faster, harder signal.
Effectively, yes. And crucially, it's not just the number of PVCs, but also their timing variability that seems particularly potent. PVCs that have variable coupling intervals.
Meaning the gap between the normal beat and the PVC isn't always the same.
Exactly. When that timing is inconsistent, it creates the most disruption to the normal rhythm and seems to be the most potent trigger for that sympathetic imbalance and unpredictable mechanical loading. Animal studies back this up. Performing left cardiac sympathetic denervation, basically cutting the main sympathetic nerve supply to the left ventricle, showed protective effects against developing PVCCM, strongly implicating that chronic sympathetic stress as a core driver.
So, variable timing equals more nervous system chaos. What about the direct mechanical stressors on the heart muscle itself?
There are two main mechanical factors implicated. First is left ventricular dyssynchrony, because the PVC usually originates from a single spot in the ventricle. Often different from the normal conduction pathway, the sequence of contraction across the different segments of the LV becomes really uncoordinated.
The walls aren't squeezing together properly.
Exactly. It's an inefficient, uneven contraction. And the severity of this dyssynchrony seems closely linked to the timing, the coupling interval of the PVC. The second factor is something called post-extrasystolic potentiation, or PESP.
PSP. What's that?
PESP is this interesting phenomenon where the force of the normal heartbeat immediately following the PVC is actually significantly stronger than usual.
A stronger beat after the weak one.
Kind of, yes. While that might sound like a good thing, getting a stronger pump, this repeated potentiation is thought to be linked to chronic calcium overload within the cell, and also contributes to abnormal loading conditions and volume shifts, which over time drives pathological remodeling and dilation.
Wow, okay, so you've got calcium problems, sympathetic overdrive, dyssynchrony, and this PSP effect all battering the ventricle. It's no wonder it can lead to CM. This complexity probably explains why clinicians need more than just the PVC burden number to predict who's really at risk. Tell us about that ABCVT risk score mentioned in the review.
Yes, the ABCVT risk score is a really valuable clinical tool, precisely because just knowing the PVC percentage isn't always enough to predict who will actually develop adverse LV remodeling. This score cleverly incorporates 4 relatively easy-to-identify factors.
Okay, let's break down those 4 factors and how they're weighted.
For sure. First is the PVC burden itself. You get 2 points if the burden is between 10% and 20%, and 4 points if it's over 20%.
So higher burden gets more points. Makes sense.
Second is the axis of the PVC on the ECG. If it has a superiorly directed axis, meaning the electrical signal looks like it's moving upwards, suggesting an origin low in the ventricle, that gets 3 points.
Okay, origin matters.
Third is the presence of non-sustained ventricular tachycardia, NSVT, on monitoring finding runs of 3 or more consecutive PVCs. That adds a significant 4 points, indicating higher electrical instability.
NSVT is a big red flag.
It is. And finally, the fourth factor is the coupling interval, CI, the time between the preceding normal beat and the PVC. Somewhat counterintuitively, having a long coupling interval, specifically greater than 500 milliseconds, adds 1 point to the risk score.
Okay, hold on. That's the one I wanted to ask about. Why is a long coupling interval, a PVC that comes relatively later after the normal beat, considered a risk factor for CM? Usually we worry more about really short-coupled PVCs, the R-on-T type that can trigger VT or VF.
That's a great question, and it highlights a really important nuance specific to the pathophysiology of PVC-induced cardiomyopathy, as opposed to the risk of malignant arrhythmias. While those very short-coupled PVCs are indeed dangerous for triggering VT-VF,
Right.
the longer coupling interval, the one over 500 milliseconds, actually allows the ventricle more time to fill with blood before that ectopic beat happens.
More filling time.
More filling time means a larger stroke volume is ejected during the PVC, and perhaps more importantly, it leads to a greater degree of stretch and wall stress on the ventricle when that premature beat finally occurs. So it's thought that this repeated high mechanical strain from late-coupled PVCs, rather than the acute electrical danger of early ones, is what drives the chronic structural remodeling and dysfunction seen in PVC-CM.
Ah, okay. So it's more about chronic mechanical stress than immediate electrical risk for the CM aspect. That makes sense. Are there other structural indicators from the PVC itself that predict a worse outcome?
Yes, besides the factors in the ABCVT score, other predictors that have been strongly associated with developing PVC-CM include having a wider QRS duration for the PVC itself, particularly wider than about 157 milliseconds.
A wider PVC complex.
Yes, which often suggests a more disorganized conduction, possibly an epicardial origin coming from the outside surface of the heart rather than the inside lining. Epicardial origins tend to cause more dyssynchrony as well. And finally, that factor we discussed regarding the autonomic nervous system, the variability or dispersion of the PVC coupling interval. Having very inconsistent timing between the normal beat and the PVC is emerging as a really critical, independent risk factor, linked not just to a higher risk of developing CM, but also to increased overall mortality.
That chaotic timing seems really detrimental. Now, we touched on monitoring earlier. You said standard 24-hour Holters often miss the true burden. How significant is that gap?
It's actually a huge gap and a major potential pitfall in diagnosis. The review cites data suggesting that a standard 24-hour Holter monitor, which is still common initial practice, will completely miss identifying nearly half, 47% of patients who actually have a clinically significant PVC burden greater than that 10% threshold.
Wow, misses almost half the cases. Why is that?
Because PVC frequency can fluctuate dramatically throughout the day and night. Many people have their highest burden during periods of rest or sleep, which might only be partially captured in a single 24-hour window. To get a truly accurate picture of an individual's maximum PVC burden and establish a reliable baseline, the current clinical recommendation is moving towards needing a minimum of 6 days of continuous ambulatory monitoring.
6 days minimum. That's a significant shift from standard practice.
It is, but it's likely necessary to avoid drastically underestimating the true burden and potentially missing the diagnosis.
Okay. So assuming we've done adequate monitoring and the burden is high, the diagnosis, like the others, remains one of exclusion, right?
Yes, fundamentally. You still need to rule out other causes of non-ischemic cardiomyopathy. You have to carefully differentiate. Are the PVCs causing the CM, or are they just a consequence of an underlying heart failure state from some other cause?
What are the typical features of PVC-CM itself?
Typically, PVC-CM presents with mild to moderate LV dysfunction, some degree of LV enlargement or dilation, and often mild functional mitral regurgitation because the valve ring gets stretched. The really defining point, again, is the reversibility. Successful elimination of the PVCs usually leads to resolution of these features, with LVEF improving and the ventricle shrinking back down, typically within about 2 to 12 weeks.
And you mentioned CMR imaging is useful here beyond just looking for scar.
Yes, CMR is vital not just for assessing fibrosis. Remember, a significant scar makes reversal much less likely. But CMR, particularly with techniques like strain imaging, is also the best tool we have for identifying subclinical PVC-CM.
Subclinical, meaning the LVEF is still normal.
Exactly. These are patients who might still have a preserved LVEF, say 50% or higher, but when you look closely with strain imaging, you can see evidence of impaired myocardial mechanics, reduced deformation. If you then treat the PVCs, and that strain dysfunction reverses and gets better, it confirms that mechanical injury was occurring even before the LVEF dropped. It proves the PVCs were the culprit.
That's fascinating, catching the damage before the EF drops. Okay, let's talk treatment. Guidelines generally suggest suppression if the burden is over 15%. How do clinicians choose between using antiarrhythmic drugs, AEDs, and going for ablation?
The primary goal is definitely achieving significant PVC suppression. Both ablation and AEDs have reported reasonably similar long-term success rates in terms of keeping the PVC burden down, maybe in the 70% to 80% range for both.
So similar efficacy long-term.
In terms of the percentage achieving suppression, perhaps. However, some retrospective data suggests that catheter ablation might achieve a greater absolute reduction of the total number of PVCs compared to drugs. And really, the biggest predictor of whether the LVEF will recover across almost all studies is the degree of PVC suppression achieved. Getting that burden down by more than 80% seems key, and ablation is often the most reliable way to achieve that level of suppression.
Makes sense. What other benefits do you see when PVCs are successfully suppressed, besides the LVEF going up?
The recovery can be remarkably comprehensive, as the review details really well. Yes, LVEF typically improves significantly, often by 10% to 15% absolute points. But just as importantly, successful PVC suppression also leads to reversal of the LV dilation. The heart shrinks back towards normal size.
Okay.
It significantly improves right ventricular RV function, which is often subtly impaired by the dysynchrony. It reduces that functional mitral regurgitation we talked about, and it lowers BNP levels.
So broad cardiac improvement.
Very broad. And interestingly, there's even some evidence for systemic benefits. Some studies observed an enhancement in renal function, particularly in patients who started with abnormal kidney function, low eGFR, before their PVCs were ablated. It really highlights that PDCCM isn't just a localized heart muscle problem. It can have systemic consequences.
That systemic improvement is a powerful argument for treating aggressively. But what about the patient who feels fine, is totally asymptomatic, but their monitor shows a high PVC burden, say 20%? Should we always jump straight to intervention?
Not necessarily, and that's a really important clinical nuance. For patients who are genuinely asymptomatic and have completely normal LV function, normal LVEF and no strain abnormalities on CMR, a period of watchful waiting is often justified.
Why wait?
Because surprisingly, spontaneous resolution or significant reduction of PVCs can occur in up to 12% of patients over a 6-month period without any specific treatment. The body sometimes just sorts itself out.
Okay, so observe first if they're stable and asymptomatic.
Initially, yes. However, and this is a critical however, for those patients who might have preserved function but also exhibit other high-risk markers. Things like having a baseline left bundle branch block morphology on their ECG, documented NSVT, PVCs originating from a non-outflow tract location, or any evidence of late gadolinium enhancement scar on their CMR.
Ah, the higher risk subgroup, even with normal EF.
Exactly. In those individuals, even if they feel okay, aggressive treatment to suppress the PVCs should definitely be strongly considered. Their potential for rapid deterioration or adverse outcomes down the line is significantly higher.
Okay, this really brings everything together nicely. We've explored TCM driven by rate, AFCM potentially driven by irregularity and atrial dysfunction even with rate control, and PVCCM driven by frequency and maybe specific beat characteristics. Despite the different triggers, it sounds like they might share some common downstream pathways: calcium problems, electrical instability, and eventually that fibrotic remodeling.
That's a great synthesis. And the overarching clinical imperative, which the review emphasizes strongly in its management algorithm, is that ACM really needs to be on your differential diagnosis. You have to suspect it, even when there seems to be another plausible reason for the patient's heart failure.
Don't just assume it's the other cause.
Exactly. If a patient has both a significant arrhythmia and cardiomyopathy, you should strongly consider the possibility that the arrhythmia is contributing, if not causing it, until you can prove otherwise, usually by seeing what happens when you treat the rhythm.
Okay, let's just quickly recap those three main suspicion triggers one last time for everyone listening.
Sure. For TCM, you suspect it with any sustained supraventricular tachycardia or frequent VT that's leading to an average heart rate consistently over 100 beats per minute.
Got it.
For AFCM, you need to consider it in patients who have non-ischemic cardiomyopathy and persistent atrial fibrillation, even if their ventricular rate seems well controlled on medications.
The rate control caveat is key there.
Crucial. And for PVCCM, you consider whenever you find non-ischemic cardiomyopathy coexisting with a PVC burden that's reliably documented to be 10% or higher, especially if you see any of those high-risk features we discussed, like NSVT or a very wide PVC-QRS complex.
Perfect summary. And the power of making that diagnosis early is clearly the central theme here. We've heard repeatedly that identifying and treating the rhythm issue can, in many cases, be essentially curative for the cardiomyopathy itself.
Absolutely. Getting the diagnosis right and acting on it early offers this incredible opportunity to completely reverse the LV dysfunction. This directly translates into less morbidity, lower mortality, dramatically improved quality of life, and as we mentioned, significant savings in healthcare costs. For a condition that's probably frequently missed or misattributed to other idiopathic forms of dilated cardiomyopathy, this really represents a chance for a true cure for many patients.
Looking ahead then, despite all this progress, what are the major unanswered questions or persistent unknowns that researchers are still grappling with? Where does the field need to go next?
Well, the biggest unknown, the one we started with really, remains understanding that individual susceptibility factor. We desperately need better insights into the underlying genetics, the specific cellular pathways, maybe epigenetic factors, that explain why some individuals develop severe ACM with a given arrhythmia burden, while others don't.
Figuring out the why me question.
Exactly. because that knowledge is fundamental if we ever want to develop truly preventive strategies, ways to identify those at highest risk and intervene before the cardiomyopathy even starts to develop.
That would be the ultimate goal, wouldn't it? Preemptive treatment.
It really would.
Yeah.
Beyond that, while the ablation trials have been very promising, especially for AFCM, we probably still need more large-scale head-to-head prospective studies directly comparing the long-term effectiveness and durability of ablation versus antiarrhythmic drugs across all three forms of ACM, particularly in the growing area of PVCCM.
Better comparative effectiveness data.
Yes. And tied to that is developing more effective long-term strategies for arrhythmia suppression and preventing relapse, especially for PVCs. Maybe moving beyond just focusing on the immediate LVEF recovery and thinking about sustained rhythm control over decades.
Okay, finally, let's circle back to that really profound point we discussed regarding both TCM and PVCCM, the observation that even when the LVEF normalizes after treatment, structural abnormalities like ventricular dilation and, maybe most importantly, fibrosis often persist. You noted this really challenges our conventional definition of a cure.
It does, and this is probably the final, most provocative thought to leave our listeners with. If that underlying pathological substrate, that scar tissue, that residual dilation, that myocyte disarray, if that truly remains embedded in the heart muscle even after the pump function looks good on an echo, how much more vulnerable does that leave the heart?
Vulnerable to what?
Vulnerable to future catastrophic cardiac events, vulnerable to sudden cardiac death due to arrhythmias generated by that scar, vulnerable to a much more rapid and severe relapse if the original arrhythmia trigger ever returns. Even if the cardiomyopathy appears cured based on the LVEF number, that persistent structural scar acts like a permanent Achilles heel.
So we might eliminate the trigger, the arrhythmia, but the damage it caused might leave a permanent structural legacy in the heart, meaning it never fully returns to its pre-arrhythmia state. Does this imply that long-term surveillance is basically mandatory for these patients, even if they feel great and their EF is normal?
I think it absolutely does suggest that. It argues strongly for vigilant, long-term clinical follow-up. It likely means we should continue optimizing guideline-directed heart failure medical therapies, even in those who seem functionally recovered, because those drugs might help mitigate risks associated with the residual scar.
Keep the protective meds going.
Keep the meds going, and perhaps we need ongoing surveillance with tools that look beyond just LVEF, maybe periodic CMR scans to assess scar burden and evolution, or advanced strain imaging to detect subtle mechanical dysfunction that might predict future trouble. We need to ensure these patients remain protected against that lingering risk of sudden death or rapid relapse. The journey really doesn't end just because the LVEF number hits 50% or 55%.
This has been an incredibly insightful deep dive. Exploring TCM, AFCM, and PVCCM really drives home the critical importance of aggressive, personalized screening, especially that need for prolonged monitoring to catch high-burden PVCs so we can identify these potentially reversible yet clearly structurally consequential conditions as early as possible.
It truly highlights the difference between just treating a symptom, like heart failure, and potentially curing the underlying disease by treating the arrhythmia, but always remembering that the scar, the history of that injury, might remain.
Thank you for watching The Funnel Effect.